We're back in session again, so let's go to the next agenda item. Number 11, Organizational Development Committee. Okay. Number 8, Budget Update and Report. Fiscal year 2017 and 2018 ended on June 30th, 2018. However, the final fiscal year 2016 and 17 numbers are not yet available. A final budget report will be provided at the next board meeting. A summary of the revenue for the first 11 months of the fiscal year is provided below. And the board received $24,946,700 in revenue originating from the following. I'm not going to go through the chart, but you guys could take a look at it. Further, as of the fiscal month 11, the board expended $19,856,000, which is approximately 85% of its authorized budget of $23,370,000. The largest expenditure categories are detailed below. So personnel, pro rata, and enforcement as in the table. And also, there's a chart below as a summary of the fund condition report prepared by the department of the fiscal year and how many months in reserve money that we have. When the board received the final budget information, staff has been authorized to work with the vice president to assess the fund condition to determine what, if any, action is necessary to address what appears to be the reduction of the board's fund. So attachment 1 includes the detailed budget charts for board revenue and expenditures as well as the fund condition. For fiscal year 2018 and 2019, the new fiscal year started July 1st, 2018. The board's authorized expenditures for the years are $25,280,000. The detailed budget information is not yet available, but will be provided at the next quarterly board meeting. Any questions from board members? Public? Item number B, board member reimbursement and attendance information, as in attachment 2. You could take a look at it. Board members may seek reimbursement for travel expenses and per diem payments. It is important to note that these figures only represent hours and travel expenses where reimbursement was sought. It is not uncommon for board members to waive their per diem payments or only request partial reimbursement of travel expenses. As part of the end-of-year accounting process, the payment of all travel claims has been stopped until the State Controller's Office updates the electronic program used for the reimbursement of travel expenses. Once the system has been updated for the new fiscal year, all board members' travel claims will be paid. A final report of reimbursement will be provided at the next board meeting. And the reimbursement and board members' attendance informations are provided in attachment 2, if you take a look at it. Any questions from board members or the public? Item number C, discussion and consideration of authorizing continuing education for pharmacists and pharmacy technicians participating in the Pharmacy Technicians Occupational Analysis Survey. The board is conducting an occupational analysis for the licensed category of pharmacy technicians pursuant to Business and Professions Code Section 139. As a part of the occupational analysis, surveys are sent to pharmacists and pharmacy technicians to determine what duties and types of knowledge bases are required to be a pharmacy technician in California. In order to increase the response rate of the surveys, board staff is recommending that a pharmacist or a pharmacy technician who completes the survey be awarded 2 hours of continuing education. Board staff has reached out to entities that offer the 2 pharmacy technician certification programs accepted in California, both the PTCB and the EXCPT. Both entities have agreed to accept continuing educations offered by the board for this purpose. Should the board agree with the staff recommendation, the following motion could be used. So we recommended to award 2 hours of CE to those who participated. Okay, you want me to move? You second? Okay, I'll make the motion and second by Stan. Any further discussion by board members? And the public? Seeing none, all right. All those in favor, please raise your hand. All those opposed? Abstain? Okay, motion's carried. Thank you very much. And, okay, attachment 1 again. Well, I think that's it for my report.
Before you go on,
Okay.
there was one thing I wanted to mention in this section because it affects the way we process things, is the way we do it now is for every committee meeting that we have, the minutes are okayed or approved in the subsequential meeting. Okay. Now, this time we had 2 enforcement meetings, and the first enforcement meeting was in the minutes. The second enforcement meeting had not been okayed, and so there's a difference between, and so consequently wasn't in the minutes, but so there's a chronological difference versus the recorded. And so it creates a degree of confusion, like when we were talking about the enforcement committee, the most previous committee was in my mind and in Stan's mind, and the previous meeting had kind of slipped from our grasp. Luckily, Steve Gray was here to remind us, but
Lord love us.
but so now, oftentimes is there a way to remedy this, to kind of highlight, even though it's not approved, kind of go over what has been
What is
processed?
your request? Would you like to have the minutes before the board meeting?
As a draft?
Maybe as a
Yeah,
draft
Mr.
form?
Draft, yeah,
so-
as a
Something like
draft.
that. So
That
that,
way we could distribute them, but it'd be labeled as a draft, and then at the next committee meeting, the board, one of the first orders of business, the committee can review and say, this is accurate.
oh, that sounds
How's
great.
that? Okay?
That sounds great.
Draft.
That'd be, it would,
That
I
would
agree
take-
that this was confusing.
Yeah, that would be
Yeah.
great.
No, I think,
Well, and also, I think in the past, in the compounding committee, when we had so many meetings and there was so much confusion, I think this is an example of something that caused some of the confusion.
one of the things we try to do is to get the minutes done relatively quickly in-house. We just don't distribute them.
Right.
So the minutes are available, so sometimes it'll be a little bit of work. If we start having bi-monthly meetings, that's going to be hard to accommodate that. But I think that for the committee to do its business, you kind of need the minutes in front of you. So that otherwise, you're going to be spending more committee time taking minutes that you're going to use in the future.
Great.
Good suggestion. Thank you. And I also want to mention one thing. Based on the recommendation of a judge at the last meeting, she actually recommended that most of the pharmacy students should attend one of the petitioner meeting that we had. So I did send out a letter to all the deans of the pharmacy school last month and asked them if they would volunteer to provide a facility that we could hold one petitioner meeting across the state, so make it accessible for the students to attend. And so September, I think we have a petitioner meetings coming up on the Friday. We have West Coast Pharmacy School, gracefully offer their facility for us to hold a meeting there. So in LA, so most of the pharmacy students in Southern California, they are welcome to attend one. I think it's very educational for the students to come and attend one of the petitioners meeting, to know what the mistakes other people's made and what is the tough process they have to go through to ask for reinstatement. So it's more an educational purpose. So make sure that once they got the licensure, they will be very valuable to hold the licensure and won't get into trouble. So we'll send you the notice later on to find out. Okay, so that's my report, and the next item on the agenda is the Legislation and Regulations Committee. Chairman Greg Lippy, please.
Thank you. Okay, the first bill that we're going to be discussing is the one that, Stan, you were asking a question about. 1751. And this is the one that would provide for interstate sharing of cures. But we had a support position, and since our support position, some amendments were made. And the amendments that were made have gone far beyond the initial policy goal of the board, as well as the measure itself, which purpose was to share controlled substances dispensing history across state lines. The amendments would allow a healthcare provider or a pharmacist who is employed by an insurer or PBM to access cures for the stated purpose of reviewing a claim. According to information received, this amendment is intended to allow insurers and PBMs to serve as another gatekeeper in the prescribing and dispensing of controlled substances. Staff notes it is the role of the regulator to safeguard against inappropriate prescribing and dispensing habits, and is a core function of our mandate, as well as the mandate of the prescriber board. As a result of the amendments and concerns, in accordance with the board's policy, I authorized a change in the board's position to an oppose unless amended to remove the amendment that they made.
My notes that I wrote to myself, I agree.
Okay. Now, however, at our meeting yesterday, based on comments received from the public, the board staff will be researching the federal requirements for PBMs to provide medication management services. As the committee chair, I will be advised of the findings, and I'm going to use the provisions of the board's policy, if necessary, to make a change. Don't anticipate it, but because of the comments received yesterday, the staff will be digging into it a little more.
So it could be that with the current amendment, that we're going to be required to, not necessarily, well, I don't know what our position would be, but there would be validity to the current amendment.
Could. I say unlikely, but it could. Okay. The issue is, because of comments made yesterday, we have to deal with them.
Is there not a HIPAA issue?
That was our concern too.
Yeah.
Actually, here comes the comments from yesterday. Hi, Steve.
Good morning, good afternoon. Steve Gray, independent pharmacist myself. What I commented on yesterday was that it's not necessarily a HIPAA issue, meaning a federal privacy issue. PBMs are contracts with the federal government to run Part D programs. As part of their responsibility under the Part D program, they are expected to monitor the care for the patients, and in fact have had to submit detailed reports going back 3 or 4 years now on all Medicare members that have been, where claims have been submitted for opioids. This came out as a demand letter, and literally thousands of records had to be submitted. What the PBM has is claims, but the PBM may have also claims from private insurers. In other words, as a Part D person, which I am now, I can also be covered under a private insurance, and the PBM can have claims under the Part D, and it can have claims under private insurance. So there was discussion about whether the PBM then was responsible for checking other records that they had. The other thing to keep in mind is PBMs are responsible, among others, for medication therapy management. In other words, there are rooms full of pharmacists at these PBM locations that do nothing but review patient records for the sole purpose of helping the physicians, the pharmacies manage therapy. And that's their responsibility. The issue here, though, is accessing cures something that is, allowed for that purpose, for managing therapy.
Right, for that purpose.
For
But
that
this
purpose.
bill is for
Right.
reviewing a claim, which we believe is
Right.
just for adjudicating the claim.
Yeah, but it would be misleading for people to think that PBMs don't look at claims. They look at all the claims. And under California law and under federal law, they explicitly, any payer is authorized to look at every claim and to look at the care behind it. Now, they can't report that information outside of certain criteria. Like they can look at a claim for Steve Gray, but they can't report on a personal basis to my employer what that was all about. I mean, there's a privacy protection there. What I was concerned about was the position the Board of Pharmacy taking in opposition might imply that MTM pharmacists can't look at claims because in this bill it says for the purpose of looking at claims. And I want to make sure that all of our MTM pharmacists who are acting on behalf of dispensing pharmacists, they're acting on behalf of prescribers, are helping to manage care. And that's
What
that
kind of
should be a
pharmacist did
legitimate-
you say, MT what?
Pardon?
What,
MTMs?
MTM?
What is an MTM pharmacist?
Under the Affordable Care Act, under the Medicare Part D program, every Part D organization, whether it be like Kaiser doing it directly or whether it's done by a PBM, they have to provide medication therapy management services. They have to look at all the claims for Medicare Part D patients for prescriptions and use certain criteria to outreach to them to make sure that their medication is being managed appropriately. They cannot change the therapy, but they have to have programs where they outreach to Medicare Part D enrollees and say, you're part of this program, we're looking at this, we're going to be contacting your prescriber and suggesting changes to your care.
But see, here's my question about that, Steve, if you don't mind. Presumably for purposes of the claims, they'd have access to all of the original or copies of the actual prescription documents and the medical records. I don't see how it advantages them at all in terms of MTM to have access to cures, which is a secondary source. It's essentially just a database of the documents that they presumably should already have. So why, that doesn't seem to me like a necessary data source for PBMs or others adjudicating claims.
And I tend to agree with you, although there will be information in that cures database about cash payment.
About what?
Cash payment purchases. So I suspect
Abuse
maybe
of the
there's-
drugs, you mean?
Yeah, in other words, when you go in
right,
and you
I
pay
understand.
cash, that claim doesn't go to the PBM because you're
Right.
paying cash. And we know that that is a way that people that are displaying drug-seeking behavior try to hide their problems with therapy. So to the extent that they're trying to help manage therapy and look at possible other, inappropriate sources or amounts or doses, perhaps that's what this is all about. I just want to make sure that people don't, who are concerned about privacy, realize that anyone who is a payer has access to all that information, who they can report it to on a personal basis for every single claim. So that's under federal and state law. Payers have access. Otherwise, they wouldn't be able to audit, set rates, and do all the things actuarially that they have to do as a payer.
I appreciate your sensitivity of the issue and your broad understanding of the issue. However,
By the way, I'm not speaking in support of the bill. I'm not speaking, I'm just trying to share some
I think that your
concerns.
bias is more with the PBM organizations because of your the organizations that you've been involved with. And I say that because it's noble to believe that that their sole purpose is for the good of the consumers and to manage care better, and that's the reason that they have these rooms of pharmacists analyzing claims and everything. I tend to have a different view of that, and it may be because my experience as a professional is different than yours, and I never did get a sense that the PBMs were acting while reviewing and auditing and recommending, if you could even call it a recommendation, rather a clawback. But I never did get the sense that their sole interest or their primary concern was the management of medications to benefit the individuals. And we're talking about the elderly now, and we're not talking about those who are maybe have a more of a issue with the age group, have more of an issue with abuse of opioids in particular, at least the cures monitors. So we're talking about the elderly, and we're talking about a variety of issues relating to pain, and to allow the PBMs to set up guidelines with regards to the care of these people that may be more legitimately in pain than maybe other, and that's a broad brushstroke, and I apologize for it. But again, I'm not quite sure if the issue is management of medication for the benefit of the patient, or is it management of the medication for another reason?
Well, certainly, Stan, you are correct in that the PBMs or any payer is going to have an interest in preventing fraud. And so they look at claims data for that purpose also. But what you may not be aware of is that the CMS expects the PBMs, because they are managing a very vulnerable group, to look at dosage, especially since the dosage recommendations from the CDC came out in terms of maximum morphine equivalents per day. And there's a lot of seniors who are very vulnerable that have COPD and other very vulnerable conditions where the CMS has come in and has said to the PBMs, I shouldn't say the PBMs because they're to the Part D programs. There's a lot of Part D programs that don't use PBMs at all to manage care. And have said to the Part D programs, we expect you to monitor all of those claims to make sure that the dosages are not going over guidelines established by CDC and others. So it is a big issue with seniors because they are so vulnerable. And then the other thing they look at is you have to monitor and report what you're doing for drugs in the elderly, like co-dispensing of benzodiazepines with opioids and so forth. I just want to make sure, and all I'm trying to say is there are a lot of pharmacists in this state and in other states across that are accessing claims data strictly for the purpose of managing therapy. There are others who are accessing it for fraud and abuse monitoring, but we need to make sure that whatever the board's position takes doesn't interfere with pharmacists who are legitimately managing patient care.
So given the patient population that we're talking about, do you still stand by your claim that it's the cash patient that is not being, there's no claim adjudication for a cash payment in this senior segment of the population?
I think your question is, are people in the senior segment also paying cash to avoid detection? The answer is absolutely yes. Absolutely yes.
That's never been my experience.
I'm a simple girl.
You're anything but a simple girl.
No, this is, to me, this is.
And don't put
real-
that in the minutes that she is one.
How can I go on with that? I think I think that we just need to recognize California law currently requires, or will soon require, a prescriber to check before he or she writes.
Correct.
Part of the reason that we want to go across state lines so that there's better information in front of that prescriber at the time he or she writes that prescription, where the patient has been, not only in California, but perhaps in other states.
Right.
The pharmacy is under no requirement to check, but exercising corresponding responsibility, we expect the dispenser to check.
Right.
There is no room in that, or there's no need to add a third party in that. It's a simple, straightforward check by the prescriber of the record, and then by the dispenser where he or she's got reason to check, and we would want them to check more often than not, and that's why we're pushing so hard to get this opened up nationwide. When 25% of the dollars we spend on medication are spent through mail order, there's a sizable chunk of stuff we can't see right now potentially, because a lot of those mail orders are out of state. There is no reason to have put into that equation the PBM at this point. That has not shown the value. That may help the PBM. It's not going to help patient care, and that is not why a prescription drug monitoring program sets up. It puts us out of alignment the way the other states set up. It is the wrong time to go in that direction.
Yeah, and as I
Okay.
indicated, I'm not saying that I'm in favor of the bill as it's
No,
currently
I
written.
heard you, but-
Okay, what I am just trying to say is that that ability to manage that therapy has proven very successful by having MTM pharmacists help prescribers and help dispensers make sure that patients are not harmed by the controlled substances they use.
Then they're already doing that, and so that's already occurring. But the onus is on the prescriber that has to check that data bank before, and the prescriber has direct access, doesn't have to rely on the PBM to grant the work.
Okay, Josh, you have Josh.
I just wanted to make two comments. One, and the second one's sort of a question, so maybe Steve will say there. But the first comment is just, there's references to HIPAA and other things. I wanted to make sure the board knows that under both federal and state law, there are allowances for sharing medical information for purposes of claims adjudication. So at least ostensibly,
issue.
this is not a HIPAA violation, although it may depend on what's being done with the information at that recipient's phase. And that leads to my second point, which is what this statute seems to be doing is specifically allowing for it for purposes of claim adjudication, which to me is very different from the MTM kind of interdisciplinary help to a prescriber that might be being provided. And that would not seem to be aided by this particular provision, which seems to be exclusively about claims adjudication.
I think we beat it to death.
Yeah, okay.
Thank you, Steve. Come on.
Robert Stein, KGI School of Pharmacy. Josh and Virginia, from the standpoint that this is clearly a situation.
Is your microphone on?
Oh, sorry. Yep. Okay, yeah. The purpose of cures is to ensure proper patient care, to ensure that all prescribers and dispensers know what's going on as far as controlled substance use. It seems to me that the PBMs have access to all of the claim information that is relevant to them to accomplish what they are supposed to be doing, which is looking for fraud and so forth. If they have access to cures, they will have access to records that they were not involved in processing from a financial standpoint, and I believe that that would be a violation of HIPAA.
Thank you. Okay, so anyway, I've stated.
Danny's
Oh,
One more.
come on, Danny.
not forget Danny here.
Yeah, I could never forget Danny.
That's Stan. Danny Martinez of the California Pharmacists Association. We agree with the board's changing position from support to oppose unless amended. We believe it is wholly inappropriate, as I mentioned yesterday during the committee.
Do you agree or disagree?
Agree with the board.
Changing of position. So CPHA had a support on this. We are also changing our position to oppose unless amended for the exact same reasons that the board is proposing
Oh,
to
good,
change.
okay.
Yes. And I also want to add, it's very sad that a bill that is sponsored by the Board of Pharmacy that has a noble purpose of sharing this information through an interstate data hub can be perverted with amendments that have nothing to do with the intended goal. And that's something that we've made sure that we are on record as saying, because we wholly agreed with the concept as originally written, and we do not support in any way, shape, or form having a third party come in for purposes other than what was originally intended. And to the extent that we can help the executive officer get the bill back to where it was, we will offer our services for that. I know that we're having conversations with the author about this amendment. His office has been made aware that we are not happy about this. I can imagine other healthcare groups are probably not happy with this as well. And again, I just want to state that for the record.
Right, and I think you said it was a board-supported bill, but we actually were the originators, so.
Correct. That's what I mean by board
Yeah,
sponsor. Yes.
So, sponsor.
Just one other thing, just want to mention that as many of you may know or maybe don't, the Cures program has already been a subject of litigation by those with privacy concerns and civil libertarians. So any, further intrusion into privacy would presumably draw additional litigation.
Thank you, Josh. Okay, moving right along.
So,
AB 1750,
may I, before you move along? It's Laura. Sorry. I know you can't tell where I'm coming from, right? It's just a voice.
I couldn't.
Would the board like to support Mr. Lippy's interim position, and then knowing that he would still have authority to explore, or
Good
did you
point.
not want to take action on that?
Well, we already, you're right, we should. Okay.
Is it an interim position, or is it a position the
It's a
board?
position, but we're just checking into it to make sure that we're staying with it. So I think you're right. We
Board
should,
should validate it.
we should
I
have a
believe the
validation.
board should speak to the concern if it agrees with that
Right.
concern about
So-
access for purposes of administering claims.
So the committee's position right now, as a result of what I have done, is to oppose unless amended.
Okay.
So we would need a vote to.
Is that a committee recommendation?
Yeah, so we
Okay.
don't need a second.
Actually, I don't think it was, because you didn't have a quorum at the committee meeting.
Oh,
right.
okay, so we still need a motion now okay, we need a motion from,
Make a motion.
a motion by
Change our
Stan,
position to oppose unless amended
right?
on the
Second by Ricardo.
1751.
Motion, second.
And any further discussions?
Any
And
more?
Do I understand correctly that's as a result of the amendments to provide access for
Correct.
purposes of adjudicating claims?
That is correct.
Okay, is that okay with you, Stan?
Perfect.
Okay, and okay with Ricardo? All right, any further discussions? If not, for those who are in favor, please raise your hands. Right, oppose? Abstain? Okay, motion carry. Oh, one.
Abstention.
Abstain, one abstention, okay. All right, thank you, motion carry. Go ahead, great.
Okay.
Thank you.
Can I go forward now? Okay. All right, AB 1752. This bill has a support position by the board, and what it does is it expands Cures reporting to also include Schedule 5 controlled substances and reduces the time frame for reporting to the Cures system to 1 working day. Is there any, are there any comments? Any?
I want to share quickly, at the time that the board had taken a position initially at the last board meeting, CPHA was supporting, if amended, on this bill. I'm happy to report that amendments that we've worked out with the author's office and in conjunction with the executive officer, we are now in full support of the bill.
Great. And yesterday, we did not recommend any change, so moving on. AB 2086. This one is supported by the board as well. It allows prescribers to request a list of patients for whom they are listed as being the prescriber in the Cures database. The board is the originator of the bill, and It was during the July 2017 board meeting that it was discovered that a statutory change was needed in order to allow the prescribers to access the reports. Any comments? Okay. AB 2783. This bill is supported by the board. The bill would reclassify specific hydrocodone combination products as Schedule II controlled substances, making California law consistent with federal law. Any comments? Next, AB 2789. This was also a support position. The bill would require by January 1, 2022, all written prescriptions issued by licensed prescribers in California be issued as an electronic transmission prescription. By January 1, 2022, all pharmacies, pharmacists, or other practitioners authorized to dispense or furnish a prescription must have the capability to receive an e-prescription.
I've got a question on this, if I may.
Yes.
So, like it or not, there's a large segment of the California consumer that looks elsewhere other than a local pharmacy for their medication, and not necessarily in the boundaries of these great United States.
Right.
So, I don't know if this came up at the Ledge Reg meeting. So, how does Stan get his prescription for Lipitor that he can send on to a Canadian pharmacy, a valid Canadian pharmacy? I don't know. Stan doesn't have a particular one in mind at the moment.
I think that particular one's no longer in business.
But how do California consumers access their medications, often less expensively? And I'm going to assume that the medication is the same medication as far as ingredient strength and stability. If
Major
they can-
assumption.
If they can no longer get a written prescription.
May I?
Good question.
I have an answer. First place, most of the time you go to an internet pharmacy, who needs a prescription? You get it online. You don't need a prescription. Stan, seriously, that's part of the problem with them. You don't need a prescription to do it. So in that case, if you're inclined to go outside the country, you could have a note from your prescriber. It doesn't even have to be a prescription because, again, you've got an international now prescription thing going on. You could make sure you get the right drug if you were willing to do this by having the specific drug written in front of you by your prescriber, and then you go online, you order the drug, and you buy it. But as we all know, and part of what we highlighted in our last newsletter, a lot of people are continuing to being driven outside the country to purchase their drugs, thinking they're getting cheaper medication, which what they're typically getting is not what they think they're getting. And even if you go to Canada, frequently those drugs are not Canadian drugs intended for the domestic Canadian market. They actually come from another country that you wouldn't suspect. So if you want to do it, you'll be able to go online, as you always can, and not worry about the prescription and get it. And the prescriber still has the ability to write scripts and hand them to you because there will still be a market occasionally for that. The whole purpose, though, is to drive it to electronic. For so many reasons, it's safer for
Well,
patients.
regardless of what we believe about the quality of these prescriptions in other countries. I mean, Canada does have a whole healthcare system that includes pharmaceuticals, and they seem to be surviving just fine. I don't know what their average length of.
But it's for Canadians, not for U.S. citizens.
Well, whatever. But so I'm not going to endorse or condemn anybody in Canada or any pharmacy, or the same in Mexico. So however, I do know that there are a lot of people that get their meds in Canada and what we are saying here is that all written prescriptions will be issued on electronic transmission prescription. All. So it doesn't say here all but a couple that might go to Canada. It says that all prescriptions. And so my concern is getting back to the elderly and the Medicare patient and those who are on a tight budget. If the bill says all, I would assume that that's all without any
There's some
exception.
exceptions, and I'm looking
Yeah,
specifically
so
for it
I
right
think
now.
the exception that, so what you're looking at is just like a high-level summary. The bill language itself, there's specific exceptions, and one of them says, the prescribing healthcare practitioner is issuing a prescription to be dispensed by a pharmacy located outside of California. So there is an exemption for the scenario you're
I'm a
speaking
happy
to.
guy then, thank you.
That's what I was looking for. Thank you, Ann.
Okay. Any comments from the public? Okay.
Probably afraid to.
Next, SB 1447. SB 1447 is also supported by the board, and the bill is sponsored as well. The measure will repeal the General Automated Drug Delivery System, ADDS, registration provisions, and the additional conditions for an ADDS located in a licensed clinic or a health facility, and would instead prohibit an ADDS from being installed, leased, owned, or operated in the state unless specified requirements are met, including a license for the ADDS issued by the board to the holder of a current, valid, and active California pharmacy license. The bill would do the following. There's 7 items here. It would limit the placement and operation of an ADDS to specified locations. It would require the pharmacy holding the ADDS license to own or lease the ADDS and its contents and require the pharmacy to supervise its operation. It would prescribe specified stocking and transfer requirements for the drugs and devices. It would require the license holder to provide training on the operation and use of the ADDS to specified individuals and require the pharmacy to complete periodic self-assessments. Number 5 would require additional conditions for automated patient dispensing systems known as APDS. 6, authorize a pharmacy inspector of the board to enter the location of an ADDS to inspect the location. And 7, require the board to report to the legislature regarding the regulations of ADDS machines on or before January 1, 2024. The measure is board-sponsored. As I said, it includes provisions approved by the board during January 2018 meeting. And board staff has continued to work closely with the author's office and interested parties to ensure that the provisions of the bill are in line with board's policy decisions. In its current form, the bill would exempt ADDS from licensure that are used in hospitals to provide access to drugs that are administered to patients. Any comments? Okay. This next group is legislation impacting the practice of pharmacy or the board's jurisdiction. Got one. Okay. Hi, Paige.
California Council for the Advancement of Pharmacy. I'm looking at Section 9, and I'm glad to see that at least the time frame in which the inspection is supposed to be done has been narrowed to 30 days after the completed application has been put in. But my question is, how long will it take to approve that location so that the machine can get in there? Okay.
I was keeping that answer secret. The intent is, once we're ready to issue a permit, we issue a permit. And the issue is getting to the completed permit stage. So if there's an incomplete permit or we've got a problem with getting out, that's part of the reason
that
that
I
there's a time
understand.
frame. So after that, it's a clerical process more than anything else.
Okay, good. And then I just have a question as to why, I understand if ADDS is being moved to a different location than what was approved already, but if it's just being replaced, why does it have to have another application?
Because something about the machine changed, we believe. I don't know. We can consider that. We'll talk a little bit about that. We're about to refine a couple of amendments that are pending, so.
I would like to.
Yeah, I think that's a good question. If it's being replaced, our intent is it goes from one form of a machine to another, so that you start with an AUDS and you end up with an APDS. Those are two different processes. And we're going to be far more concerned about the medications that are being dispensed from a machine than those that are being used for administration within a facility.
And I'm thinking of nursing homes.
Yeah,
and the-
that's kind of the clarification, though, so let me see if we can figure out what to do there. Thank you.
Thank you. Okay, as I started to say, the next group is legislation impacting the practice of pharmacy or the board's jurisdiction with a board-established position. These bills can be found in attachment number 2. First one is AB 1953, and this board has a support if amended position. The bill would require disclosures by an applicant for a license to operate a skilled nursing facility or by a skilled nursing facility licensee relating to an ownership or control interest of 5% or more in a corporation, sole proprietorship, or partnership that provides or is proposed to provide any service to the skilled nursing facility. During the public comment period, comments were received regarding the scope of the board's amendment. Public comment suggested that it may be appropriate to extend disclosure requirements to pharmacists providing clinical services. Staff will research the issue. As the committee chair, I will be advised of the findings and will use the provisions of the board's policy if necessary. The board had voted to support the measure if amended with the additional provisions that would require disclosure to the board of any relationship between a pharmacy and a SNF. The author was made aware of the board's position and suggested amendment, but has not yet included it in the bill. Any comments? Okay. Coming up? Come on down.
Hallie, CCAP. I just wanted to say that the California Council for the Advancement of Pharmacy is in support of this bill, but we would also be in support of it if your amendment was added.
Great, thank you. AB 2138, the board's position on this is opposed. The bill would place significant limits on the board's enforcement process, including limits on when a board can deny, revoke, or suspend a license based on a conviction or other act, and limits on the length of probation. It also limits the board's time frame to decide on a petition to modify probation to 90 days. The board has significant policy concerns that this measure will negatively impact the board's ability to thoroughly review and consider criminal arrests and/or convictions of applicants and licensees, which could significantly undermine the board's consumer protection mandate. Amendments to the measure have removed some of the more restrictive provisions of the bill, but do not make sufficient changes to remove the board's opposition. Multiple boards in the DCA similarly oppose the measure. Comments? Okay, next, AB 2256. Board's position is support. The bill would allow law enforcement agencies throughout the state to acquire naloxone from a pharmacy, wholesaler, or manufacturer without a prescription if it is exclusively for use by employees of the agency who have completed training in administering an opioid antagonist, and acquisition and disposition records are maintained by the law enforcement agency for 3 years.
Just an extraneous question. How's the price on naloxone doing, or a generic equivalent there?
I don't know, but I've heard it's going up, up, up. Is that true?
There have been some philanthropic donations for use of it, often with extraordinarily short expiration dates, by the way. But I think it's all over the place. The prices got high, and then there have been some public health binds of large quantities of naloxone that they distribute, so that kind of help offsets the cost. But like everything else, I think generally the price has been going up. It's the minute demand hits, it.
Yeah, it's a shame, because how important it
Like
is.
that EpiPen thing with.
Right, exactly.
But there are some funding sources out there that are providing the medication for either less or for, as a donated product.
Danny?
As a quick answer, I believe the last price that I saw online for, kind of like the GoodRx website was an average of $132 for a kit.
What was it before?
I believe somebody can correct me if I'm wrong, I believe it used to be anywhere from $20 to $40 for a kit, and because of the opioid crisis and the ensuing consequences, it's gone up in price. Obviously, we support the bill, first off, fully support the bill, but yeah, that is a concern that we have heard from some of our pharmacists and some of the patients that that this is becoming a big concern, so.
Thank you. Okay, next is AB 2576. Board's position is support. The bill would grant authority to clinics to furnish dangerous drugs to several entities, pharmacies to dispense drugs without a prescription, and the board to waive any requirement in the relevant chapter during a state of emergency. The board currently has authority to issue temporary permits, as well as a process to waive certain requirements in the event of a declared natural disaster. Many of these provisions currently only apply to a pharmacy. Allowing greater flexibility for clinics appears to be consistent with the board's policy of ensuring that displaced patients have ready access to prescription medications. Board staff provided technical input to reconcile the provisions with the current law. Amendments made to the measure on June 27th now extend the policy beyond response to declared disasters by expanding the conditions under which a clinic can provide medications to someone other than a patient. Board staff has requested clarification from the author's office on this provision. Staff will have a recommendation after additional information on the issues obtained. And did we have something?
Yes,
I think
so
we did.
when we understood what their policy goal was, we provided some technical input to help them craft the language so that it would apply to just the declared emergencies, which is the policy goal.
Right. Okay, thank you. Any comments?
We'd like a change.
You want to, oh yeah, right.
From support if amended to support. Oh, sorry.
We have a support.
Never mind. I thought it was an SIA. Sorry. Sorry for the distraction.
That's okay, I understand. AB 2859, board's position is opposed unless amended. This would require community pharmacies that dispense Schedule 2, 3, or 4 controlled substances to display safe storage products within the pharmacy. Following recent amendments to the measure, the executive officer worked together with me to establish a neutral position on the measure. The position is being brought to the board for ratification.
It could be.
Could be. It's
A lock on
various
the cap.
things that have been designed to store these products safely so that the kids can't get into grandma's medication.
Mike, please.
No, it's the grandkids.
Stan, just to further clarify, what I discussed at the last board meeting is that device that has the combination on it, that's the safe storage product. I'd like to, so at the last board meeting, I mentioned that CPHA was very much opposed to this bill. And I am happy to report that after working out amendments with the author, we are now neutral. I believe the bill is now pretty much an optional thing. There's a couple of folks that actually have to do this per this bill, but independent pharmacies are no longer required to do this, which is what we were asking for. And so I'm happy to report that we're neutral on the bill.
Thank you. Okay, so the committee recommendation yesterday was to bring this to the board for ratification of my neutral position. And because we didn't have a quorum, it can't be a committee position or a motion, so.
Okay, so do you need a motion to change it from oppose and as amended to neutral?
I do.
Okay, anybody want a motion?
Because of the fact that oh, I have to remember.
It's because it's
Okay,
gone
because
from
of the
mandatory
recent
to
Yeah,
missive.
because it's not mandatory anymore.
And we were left hanging out there, and there was no
Yeah.
longer any position. We worked with the author as far as we could. We're not supporting the bill, but we're not opposed to it any longer. No, the bill was
No,
amended.
it was amended.
And the amendment,
The bill amendment takes what used to be a mandatory requirement that pharmacies display these devices to make it optional.
okay.
That was why we had our previous position, so they fixed it.
Okay,
So we have a motion.
we need a motion to, moved by Debbie.
Yeah, I'll move that motion.
Need a second? Second by Cheryl. Any further discussions? If not, all those in favor, please raise your hand. Oppose? Abstain? Okay, motion carry.
Good. Okay, 2863. The board's position is support. The bill would limit the amount a health care service plan and health insurer may require an enrollee or insured to pay at the point of sale for a covered prescription to the lesser of the applicable cost-sharing amount or the retail price. Any comments? We'll move on. SB 1109. Board has an oppose unless amended position. The measure contains provisions requiring education on the hazards of opioid use. The bill also contains a provision that an additional warning label be attached to all opioids dispensed for outpatient use as proposed in section 4076.7 of the bill. The board discussed the measure at the May meeting and voted to establish an oppose unless amended position, requesting an amendment to remove the warning label requirement while supporting the remaining provisions of the bill. For the board's policy, we changed the board established position of oppose unless amended to neutral on this because basically there was no opposition to it. So I guess we would need a ratification of that as well.
So did they amend anything at all? I mean, that they still require that mandatory,
It's a label, it's a flag label that they put on. It's not red, it's just a simple flag that they could put on to it. And there's 5 words that are required to be on that warning, I think.
Right, our main concern before was we thought it was going to be this, glaring red label that, would attract people to it. And so that was our concern, but that's not what they're doing.
Danny Martinez from CPHA. This is another bill that we have also worked with the author's office on to reach a neutral position, thanking the executive officer. And I'll restate my apologies from yesterday for the confusion that I had at the last board meeting with the executive officer. Our lobbyist, and I was not made aware of this, our lobbyist was in negotiations with the author's office on getting to a neutral position. So, thanks.
This is an important bill, and the author's office worked really hard to remove opposition on this bill. And we worked with her as hard as we could, much like CPHA did.
So I'm sorry, can you explain again what so
It's
they
a-
took off the labels, I mean, the little
They
auxiliary
reduced-
labels, is not required?
No, the label is still, they want a label on it saying opioid handled carefully or something. I'm looking for the exact words in the bill. I'm too busy listening. But it's 5 words, and they had demonstration bottles that they had that showed that you could do it with a flag if you couldn't fit it on the label. You know how they fold the flag over?
So I
on-
guess, what was the comment that people wouldn't be able to identify? It seems like they still would be able to identify opioids in your
Well,
inventory.
they'd have to read the label, but it wasn't read. Before, there was a version that was going to flag that these, so the concern was somebody would go into a pharmacy, into a home, see the flag and know, oh, this is the one I want.
So now if they just read.
Now it just provides a notice, they have to at least read the
And
label
now
a little
that
more
they'll see a
carefully.
label and say opioid.
Yeah, the label will be on it, but it won't be a flag label in the sense of a bright red neon flashing light.
Plus,
I mean,
the label's going to say hydrocodone anyway, so somebody, I mean, if it is.
Is this a
So-
strip label we're talking about?
Yeah, like an auxiliary label.
Like a
auxiliary
auxiliary label, like a little auxiliary, you stick the auxiliary label to it, or if it contains just a
Patients.
statement, would they accept that, or it has to be auxiliary label? If they type a statement on the label,
Label itself?
yeah, the label itself,
Yeah.
that would be acceptable.
Yeah.
Okay, well, that'll make it
Okay.
easier, right?
Well, I mean, I guess I still, I mean, I think our concern before is we're saying, here's the opioid. Now, okay, so the auxiliary label is not red. We're still saying, here's the opioid, you know, so,
Well, how's that really much different from looking at the label and seeing Vicodin, hydrocodone? I mean, people
I
that are
agree
after
with-
it, they know what it is.
I mean, I agree with you, so why overregulate this thing? Why say, okay, pharmacy, you have to put on another label because you already have a label that says this is an opioid, now let's put a label that says it's an
I
opioid.
think because we're saying that it's not that big a deal to accept that in order to get the rest of the bill that we want.
No, wait, I don't understand what you're saying. To do what?
The rest of the bill, we want, what's in there is what we want. This one provision here, we're saying we can live with.
The actual wording, just for clarity, is caution opioid risk of overdose and addiction. That's relevant consumer information to our way of thinking, and so that's why we took the position. And we couldn't go any further with the bill. I mean, and then it left us as the sole opponent out there to an author that had worked really hard to remove opposition, and we're not supporting the bill, we're not, well, actually, in this case, we are. Never mind.
Are we going, I thought we were going neutral.
We're
Are we
going-
neutral?
We're going neutral.
Okay, all right, because the problem is that we didn't go as far as we didn't get everything we wanted, but this was a compromise that seemed to provide the consumer with some knowledge that he or she may not have. But I think your point about the hydrocodone is,
It's there.
Page.
Page.
This isn't about this bill.
Uh-oh.
I asked
Wait,
about.
Paige.
we finished this argument first.
Yeah,
you through
stay
with this
there.
I'll stay.
Okay, so, do we have
All
a
right, so
motion
you need a motion to
for a
change
neu-
it
to ratify a
uh,
neutral position?
from oppose, that's amended to neutral. So we need a motion from the board.
I'll make it,
Make it by Greg. I'll second.
okay?
All right, motion by Greg, second by me. Any further discussions? If not, all those in favor, please raise your hand. Oppose? Abstain? Okay, motion carry.
Okay, thank you. Now, Paige.
Okay, thank you. I just need some clarification on 2859 Caballero bill.
That was a couple bills ago, right?
859,
Yeah, that
859.
was before
that
2862.
You took away your oppose
big
unless
storage
amended.
deal.
Right.
Yeah.
But I don't see anywhere in this bill where
Was changed?
no, it still says it's required and you shall display it.
Anne and Laura are discussing that very question right now. On 2859, whether the language, is the language just not in print yet, or are we confident that it was changed from mandatory to optional, or?
It appears, based on our read of it, that it is mandatory for certain types of pharmacies, but it only applies to, it appears to be chain pharmacies primarily, and that it's independent. It's
There's an
weird, like,
exception
as
in
I'm
there,
looking
too.
at that, that's where the, I think, permissible piece comes in, is their definition of pharmacy for purposes of this section carves out what appears to be like independence and things like that.
And the National Association of Chain Drugstores was neutral on the bill. So otherwise, we would have been basically carrying something that wasn't even ours to carry per se.
Okay, well, they define independent pharmacies as having no more than 4 pharmacies.
Right.
And we have a member who has more than 4, but they're independent, they're small. So they will be
So what was your
required.
position on the bill?
Oppose.
Okay, and are you still working the bill with the office?
Yeah, but I don't think it's going to change.
Yeah, she's not going to change, I know.
But I did, yeah. So I just wanted that clarification on,
Well, is this going to change anybody's
That's up to the board. I mean,
feelings
we
here?
went with, when CPHA came off the bill, it kind of left us out there.
Right.
So, no, this is 2859.
My
And so we've
concern
gone
is-
from it's required to it's not required.
No,
Wait,
required.
our last vote was that it's not required.
yeah, so I'm saying, what I was going to say is I think we may have to revote it.
Well, I think we do, and so the definition of a chain is 4 or more. Is that right?
I
More
think it's
than
more than
four.
four.
Definition of an
No. But in
The
this,
chain would be more than 4.
and so in this bill, if you have, how many pharmacies are you considered a chain?
More than
5.
4.
More than 4, so that'd be 5 or more.
Right.
That's not much of a chain.
You had more than 4.
No more than 4.
So they have to satisfy 2 prongs in the bill to be exempted, as I understand it, or for it to be permissive. It's owned and operated by a person or persons in which the majority of the beneficial interest, as well as the management and control, resides with at least one board-licensed pharmacist. And then the owner and operator with the beneficial interest, management, and control described in subparagraph A owns, operates, and has management and control of more than 4 pharmacies.
But also, doesn't the bill state in there that if they say it's a financial burden or they don't have access to the product or whatever they can get out of it?
So that's specific to sanctions. So it would be with returns to whether or not the board would enforce against it, which is,
Right.
I feel like slightly different. Do you know what I'm saying? It would still be a violation of law. It would be whether or not they are sanctioned for it.
And I may have misheard, but the second element is that the person has management and control of no more than 4. Did I?
Yeah.
I think I heard it said the opposite.
I
just
think you
wanna
did.
clarify.
That's how I heard it as well, at least.
And so,
No more than 4. Yeah, we were saying that more than 4 would constitute a chain.
so more than 4 would be subject to the requirement that they have safe storage products displayed in the pharmacy.
So I think because of the misunderstanding, we have to revote it.
So just procedurally, I would recommend that you make a motion, somebody make a motion if they would like to do that, to reconsider the prior action.
I'll make
You
that
vote on the
motion.
reconsideration and then basically.
Okay, well, I'll
start
make it because I had wrong information. So,
So what is your position?
reconsider.
You want to reconsider that and change it from the opposed and this amended? We did change.
well,
it to-
I would still support
neutral, right?
neutral. I
You
would
can
still
do
support
neutral.
neutral, but I think we have to reconsider because of the fact that we voted under the impression or understanding that it wasn't mandatory anymore, and it still is.
This initial vote is just to reopen the vote.
Okay.
So
It's
this
just
is
a
not
vote
a
to
vote on
reconsider.
substance. This
Consider.
is just whether you want to reconsider the prior vote, which
Right.
changed the position.
So my
Okay.
motion is to reconsider.
Motion is to reconsider, okay?
That's a motion.
Yeah, motion by Greg,
Do we have
Any-
a second?
second by Ricardo. Okay. All right, any further discussion? If not, all those in favor of reconsider, please raise your hand. Okay, oppose,
Alan only raised it halfway.
abstain? Okay, motion carry. Go ahead.
Okay, so now, do we have a motion to ratify the neutral position? No, we don't. Yeah, we do. We're reconsidering it, so now we have to revote.
Our original position was opposed unless amended.
Yeah, it was opposed last time. I changed it to neutral.
And-
Oh, I'm sorry, so I thought we voted to neutral, and I thought
Did.
the reconsideration would only be if we wanted to change that neutral.
No,
That was just to revote.
To ensure
was
you
to
had the
revote.
right information in front of
To-
you at the time
All
you
right,
voted.
then,
Right. Now
You
you-
so the question,
want, you can change my last vote. I misunderstood what I was.
no, I'm not saying I want to change it. Oh, all I'm saying is we are now reconsidering it.
So I would
And we
vote
now,
to,
we now
I would
will,
have voted yay to reconsider if I didn't understand that that was the purpose.
okay, fine,
But you had a unanimous to reconsider now.
okay.
All right, change the vote,
Now
Laura.
that we are have voted to reconsider, and now that we have facts that we didn't have before, does somebody want to make a motion to ratify the switch from opposed unless amended to neutral?
I'll make that motion.
Okay, motion
Okay.
by Debbie. Need a second? Second by Ricardo. Any further discussion?
Okay,
Right.
now we have
Now
more
we have
discussion.
comment from the public.
Taking much longer than I did.
Steve Gray, a pharmacist. I just want to thank one page for hoping to clarify this. As I understand the bill now, and I would like your input, is the bill would only require a pharmacy to display it. And it would require the Board of Pharmacy to enforce it,
Right,
If we chose.
if you chose. But it wouldn't require the pharmacy to actually put the medication in a vial that had a lock feature.
Correct.
correct.
They're just displaying it. Isn't there a danger, and this has happened in other places, that the patient then will say, okay, I want to buy this unlabeled vial, and they sell it, and then they transfer it. Now you've got the medication in a locked, unlabeled vial. Or they're going to buy these vials, take them home, transfer all their medication, because they're concerned, valid concern perhaps, but now this whole thing seems to set up a scheme where you're going to end up with a lot of medication in unlabeled vials, because there's no requirement in the bill that the pharmacy actually use the locked vial or other device to actually dispense the medication.
Wouldn't our
Well,
regs
and if-
require that the vial be labeled, though?
Yeah, I would think so.
Not necessarily. It just displays, all the regs require, all the bill requires is that you just display that these are a product that's out on the market. It doesn't require that the pharmacy actually use them at the patient request.
But I would like to hope in that situation, if the patient really did have the intent to use the container for what it would be intended for, that they would also ask to have it appropriately labeled, sensing that there'd be a value. I think part of the value of these devices are that they're intended for long-term use, not just for one vial or one dosing regimen. But the bill doesn't address that. I don't know what to do with it, because they could put it in any kind of container. They could put it in one of those kids' safes now and lock it up.
Right.
And
Yeah, I
it
mean,
still wouldn't be
you know,
appropriately
It
labeled.
doesn't define it. And then the question, for just a minute, just the question is, does this apply then to mail order? In other words,
No.
okay, so the medication is going to be received, 80% of refills for long-term care are received now from mail order pharmacies. I don't know the right number, but we know it's
50.
big. And then now the patients have all this medication in their house, and they go to the pharmacy and say, I want to buy those vials, and I'll put it in myself. I just think it's a bad bill, and I think we really need to think through the unintended possible complications of this, because it doesn't really say what's going to happen here. And the Board of Pharmacy is charged with enforcing it.
My concern is, now our inspectors are going into, Stan's drug number 5, and they're checking my OTC stuff, and if I don't have this, now Stan's drug number 5 has a cite and fine.
Well, I don't think it says,
We wouldn't necessarily.
Well, so I want to speak about one thing in the bill that might address that. The language in proposed subdivision C, it's on page 4 of the bill. C1 says the board shall assess a fine in an amount to be determined by the board for a violation of the section. And then there's an exclusion for when the board can determine that compliance, if it would create a financial hardship or that the pharmacy is temporary out of stock. But it doesn't say may, it says shall.
So this goes back to an expanded discussion we had yesterday, where now Stan has got a citation for the world to either view or not view. And the reason he's got it is because he on his shelf, one of the pharmacy board inspectors didn't see a little gizmo that's supposed to be a consumer protection. So, I mean, to me, I don't know, I mean, this is just problem after problem. Do we want our inspectors to go in and start inspecting over the counter, making sure that this guy's got inventory of specific items? And do we want that to become a cite and fine for a licensee? I mean,
Oh, you should probably oppose the bill. Ooh, if the answer is no to that, then that's an opposed position on the bill, probably.
I know my vote.
Yeah,
Probably
if
everybody else
if
does,
it's a
too.
bad bill, you could oppose to it.
Yeah, absolutely.
Okay, so what's the status now? Do we have a?
I don't have a second on the motion. Oh, we do.
Yeah, we do.
We have a motion,
Debbie and
We have a
Ricardo.
motion and a second.
with a
For-
motion
Ricardo's a second.
by Greg, by
Oh, the
Debbie,
motion
second by
was-
Ricardo. All right.
Motion was Debbie, Ricardo was
To
the second.
change, still to put it back in neutral, okay? So all those in favor, please raise your hand.
This is for neutral?
For neutral.
Neutral. All right, all those in favor, please raise your hand.
Opposed?
No, this is
In favor,
for neutral.
okay,
To
from,
go
to
with
neutral, okay, all right.
Did you count, Laura, did you?
I don't
All right,
think the
please
hands
raise
were
your
up.
hand for those in favor of moving it to neutral position. All right, and all those opposed?
I'm counting
Is
a
that
tie.
even? Is
I'm
that a
see-
tie?
Abstain? One abstain. All right, so you got to count, Laura?
What is it? Okay.
Okay,
so
all
it
right,
carried.
it's motion carry.
Okay,
That it carried?
yep. Okay, SB 1442. Board has a support position. The bill specifies that a community pharmacy shall not require a pharmacist employee to engage in the practice of pharmacy unless the pharmacist is assisted at all times by another employee as specified. It's my understanding that the chain stores who were opposing it now no longer oppose it, and we have a support position on it. And that's it. Any comments? Moving right along. The next group are legislation impacting the practice of pharmacy or the board's jurisdiction without a board-established position. So these are possible action items, and because we didn't have a quorum yesterday, we could not come in with motions, but we do have a couple of them that we are making recommendations. The first bill under this category is AB 1753. The measure would reduce the number of authorized security printers approved by the DOJ to 3. We beat this thing to death. We decided not to take a position before. So, okay. Are there any comments? Okay, next, AB 1998, Safe Prescribing Policy. By July 1st, 2019, every healthcare practitioner authorized to prescribe Schedule II and Schedule III opioids must adopt a safe prescribing protocol as specified, including a requirement that a prescription for naloxone or other opioid antagonists be offered when prescribing opioids to patients that meet specified criteria. This bill requires CDPH to report to the legislature annually on data relating to such prescriptions issued in California. The board has routinely supported and focused efforts on combating prescription drug abuse, and this falls within that category. There have been recent amendments to the measure, which now include a hospital pharmacy and therapeutics committee as an entity required to develop a safe prescribing protocol. Further updates.
So is that P&T committee, is that for the hospital entity, each hospital entity, or is that more a general? Like there's a committee that's calling themselves a hospital P&T, and they're going to provide a safe prescribing protocol for the state?
I'll let Jenny answer that one.
I'm not prepared to answer that question.
So I don't believe it's a statewide protocol. I believe that it is envisioned facility specific.
Okay. Now, this one says that the subcommittee recommended support. I don't have that on my notes, but anyway, it's at the board level, so do we have a motion to support?
All right, do we have a motion to support from the board? Neutral
Or no position.
or no?
We don't have a position.
You have a
so-
support, opposite to the
Any comments?
support? Any discussion?
We don't need to take a position on it.
We don't have
unless-
to. We
don't have to take a
unless
position
we
then,
want to
okay.
oppose, if there's an oppose, that's a different thing. but-
Okay.
Okay. Let's move on to AB 2037. This bill would allow a pharmacy to provide pharmacy services to outpatients in an entity covered under Section 340B through the use of an automated drug delivery system. The measure is similar to last year's SB 528. The board established a supportive amended position on that measure. As part of its request, the board requested that the provisions not be limited to just 340B clinics. The board's amendments were not incorporated into the measure last year, and the measure ultimately stalled in committee. Staff is working with the author's office to do double joining language with the board's ADDS bill, SB 1447. The subcommittee did not have a recommendation on this, so unless I hear a motion, I'm moving on.
40B clinic, I mean,
It's that we didn't want it to be restricted only to 340B.
okay.
But we have the ADDS bill of our own that removes, that goes into a slightly different direction. They're basically similar provisions. In fact, if anything, 2037 is more succinct. It's just real compact with respect to its provisions. So we are doing double joining amendments this week to blend the two bills so that they don't influence each other and to standardize between the two so we don't have a term in one that isn't in the other.
Because it doesn't, I mean, it's not a bad idea, you know, I mean, and it's even not a bad idea if it is just limited to 340B clinics. I mean, I can understand how it would be a lot easier to have it everywhere, but.
We voted against it last year because of that.
But it's not a bad idea, you know, those clinics are mostly there for, you know, people who are struggling with
Right.
the cost of everything. So it seems like, I don't know, to me, it just seems like, you know, you have people in need, and it's a 340B clinic, which designates the type of patient population that you're dealing with, so.
So do you want to make a motion to approve?
I'd make a motion.
I don't think it's, you know, it's regulation where it's not needed.
Say it again?
I think it's just regulation where it's not needed. Because I think 340B clinics are usually supported, you know, like in hospitals and whatever, and they're supported by pharmacy departments already. I'm not sure we need to.
No. This is different than that. This allows for it to, let's see, does it
Use
state
the
that it's in
ADDS.
clinics?
Says provide pharmacy services to outpatients, an entity covered under 340B.
Okay, what they're referring to here is outpatient clinics that are unassociated with a hospital.
I was
and-
thinking of like these birth control
So the
clinics.
federal-
The
those federal clinics?
Those federal clinics, right.
But a lot of those federal clinics then direct them to pharmacies, so they're getting pharmacy services.
Well, I think you do have a point there. I guess that those drug delivery machines, whose drugs would be owned by a pharmacy, are in competition with other pharmacies. I think the idea is to make sure that when they go to the clinic, that they indeed get the drugs right then. The number of people that follow up on it.
Right.
There's the intimidation factor, there's a fear of cost, there's a whole variety of things. And I think the thrust of this is to make sure that they get in those federally subsidized clinics, that they get their drugs right then. I think Stan's right, the inclusion of non-340B drugs kind of dilutes the power of this. So I think for what the author intended there, I think we should support it because it allows access to medications that they most
so-
likely will get and cost the health system more and affect the public health.
Well, and the
So-
pharmacy's still in control of the drug supply, which
They'd
is
have to be.
important.
Yeah.
So do we have a motion?
I'll make a motion that we support it.
Sounds like we have a second.
All right, we have a motion to support by Stan, second by Alan. All right, all those in favor, any further
2037,
discussions?
right?
Well, we can't vote yet, we have to.
Public comment?
Comment.
2037.
Steve Gray, pharmacist. My machine just ran out of battery. How does this differ from the board's bill? It talks about allowing the use of ADDSs in a location. And would those locations that we're talking about under the board's bill be able to use the ADDS for dispensing anyway?
Probably, but this one's set up dedicated. This is one where the author spent a lot of time making sure that he's got this niche. We have a different bill that does essentially the same thing. I think at some point down the road, the two provisions can be merged.
Okay.
This isn't that time.
Is
But
the
Mr. Bonta is very serious about this bill.
okay? Is the board's bill allowing the ADDSs to be used for dispensing
In clinics, yes.
in licensed clinics?
Yes.
Is
That are
this
licensed with
bill
us.
also limited to licensed clinics?
This is intended for clinics where they're providing services to 340B patients.
Which
As I-
aren't necessarily licensed by the Board of Pharmacy.
Says including nonprofit and free clinics.
Which we do license.
Nonprofit and free clinics.
That's all, right?
Okay, this is what it said, it says, the pharmacy law authorizes a pharmacy to provide pharmacy services to specified licensed health facilities through the use of the automated drug system, owned and operated by the pharmacy, that need not be located in the same location as the pharmacy. The pharmacy law also authorizes specified health clinics, including nonprofit and free clinics, to use an automated drug delivery system operated under the authorization of the pharmacist and under which a clinic is responsible for the safe and security of the drugs in the system.
Reading from, I'm sorry, I don't have it
I'm
in
reading
front of
from the Legislative Council.
me. Yeah, I guess, I got confused. Is
Well,
it,
actually, it says here in subdivision 8 on page 3, this is 4119.11 A11, notwithstanding section 4107, which is the section that bars us from having duplicate licenses in the same place.
Right.
The board may issue a license for the operation of an automated drug delivery system at an address for which it has issued another site license. So there's
Right.
one permissive, that it can go anywhere we've already licensed. That's about as close as the drug, and last year they were talking about putting them in board licensed clinics, and I don't think that there's a difference in the bills from last year to this year.
okay, and,
But we want some control, and again, we've got the control with respect to the fact that the pharmacy's got control of that machine.
right. And the other thing, just, for those of you that may not know, the drugs that are bought at a 340B discounted price do not have to be sold to patients who are indigent.
All right.
But they have to qualify.
No, the entity that gets the drugs has to qualify for our disparate impact. And the extra profit they make from those drugs, selling them to patients who will pay cash or otherwise, allows the entity, such as to use the money to treat independent patients. So these drugs actually compete with other pharmacies that are buying drugs at higher prices at wholesale because they can be sold. That's why a lot of community pharmacies want to sign up for these programs, because they share a portion of the increased margin and profit with the entity that qualified to buy the drugs in the first place.
But as I read this, Steve, allow a pharmacy to provide provide pharmacy services to outpatients in an entity covered under Section 340B. So reading this, it says that this automated drug delivery system is going to be in an entity covered under Section 340B.
But it doesn't say
Please,
that the
sir.
drugs have to be sold and dispensed to patients who are indigent.
Well,
Right.
wouldn't
I mean,
that be
that's a very
patients?
key point and very controversial point.
But I understand where 340B drugs don't have to be sold just to indigent patients.
Right.
I understand that. But right here, doesn't this refer to, it's a clinic servicing 340B patients?
But those clinics don't only serve indigent patients.
Somebody who's not indigent
Well, I
can
think
walk
we're-
in
It
there
does
and
not
get
have
the
to be a
drug.
free,
But
nonprofit
I think
clinic.
that the same would be true for a hospital, right? A hospital, it might be 340B eligible, but they serve a larger population than just the indigent. So I don't know that what we're discussing right now is limited to what is being proposed in this legislation.
Well, but I'm not quite sure what your problem is, Steve. I mean, my issue is that it's gonna get to 340B eligible patients. I mean,
Under the presumption that that's the only place that these drugs are sold to.
well, and if the clinic also treats patients that aren't indigent or don't qualify, and I'm fine with that. Because it's not against the law. So I don't have a qualm with it. My issue is the availability in clinics where and I've got a specific clinic in mind, which is a clinic that is a women's clinic, and I could see where this would fit perfectly in a women's clinic, and especially for indigent women.
My initial concern was whether this would open up these ADDSs to be used for this purpose in clinics that are not licensed by the Board of Pharmacy. And I think you're right in that some of those clinics will be licensed by the Board of Pharmacy, but it doesn't say that the clinics that they're talking about have to be licensed as the board.
Well, I'm looking just at the information, and one of the things it says, the bill would require certain things if all the conditions are met. And number one is the pharmacy obtains a license from the board to operate an ADDS.
But not necessarily the clinic. In other words, the pharmacy obtains a license from the board to operate the ADDS.
So,
That'd be okay, that may be all that's required.
so if I can
It
just.
doesn't say the clinic has to have a license.
So I think one of the things that I would recommend is, as you're considering the policy here, the board has already made policy decision and is pursuing legislation that would allow for the use of ads in places where healthcare services are provided, which would be a clinic that is probably not, which would include a clinic that is not licensed under 4180 or 4190. So I'd recommend that you maybe look at these. We're going to be doing double joining language that would help to harmonize the two, but the provision that I think we're kind of talking a little bit about is already addressed.
And I'm also a little concerned that there's no opposition addressed to the bill, nor was there last year, until we came in and said we wanted to apply to all. And so if this is such a potential problem for pharmacy, but I'm trying to figure out why pharmacy would be opposed to this. I don't understand. That's what I'm.
I don't
I'm
see
trying
it
to
either.
I'm trying to understand the argument.
He's
That's all.
saying it's a competition issue.
Maria has a comment. Maria?
Comment.
Yay! Welcome
And,
to the
and
board.
it may be from a naive point of view, but I am concerned about all the detail that's in the bill, and especially since we have a bill that's sponsored by the board that has covered this issue in detail, that it just is going to what Debbie had said earlier, is what's the need of this legislation when it is duplicative and could be potentially confusing, because now you have repetitive information on a similar or same issue in different parts of the code. So value, and for making it easier, I think it would be nicer to merge the two issues, or at least be in the same part of the law.
And we tried that discussion at the beginning of the year. We had the two authors' offices together, and they could not merge them together. which is their prerogative. They each wanted their own bill, and that's what we're dealing with here. So if at this point, for us to come in and oppose Mr. Bonta's bill, it's going to be viewed as a late hit. And we understand. I think that what we do is, if we can, move forward with both bills unless there's specific provisions we want to put in either or both bills. But then look forward to a point, maybe during sunset review in a couple of years, to move them together a little more closely if there's some divergency. Basically, they do the same thing. One is just set up in this one code section. We've got 1447, which was drafted by our attorney, that went in a different direction. But the general parameters.
And just to respond to Jenny, I can see the importance of working with the legislators and the sponsors of the bill so that we are in a collegial way of doing this. But when you look at the details of it, I mean, if there's any way of eliminating a lot of the details, because you look at, it's opening up so many different things. It talks about how it's labeled, the details of how it's processed, so many other things. It's just completely like a rewrite or a copy-paste of other regulation, other legislation. So how you could actually operationalize that and be correct, I'm not quite sure. But I'm concerned about the idea of our regulations and laws are already so complicated. Why do we need to have them written 2 and 3 times in different code sections?
Well, we tried.
So, thank you.
I think Stan's concern about this is if we don't get this passed, and if we work to join it with the other bill, this is going to fall by the wayside like it did last
Right.
year.
I think long-term, that's probably what's going to happen too.
But I have a question though. You know, on the bill SB 1447, we're talking about this ADDS that you require that the drugs going to be in the machine owned by a pharmacy. But now when you do the 340B, the drugs are not owned by the pharmacy though. The pharmacy only got the dispensing fee. So the drugs are owned by that clinic. So is that a conflict of interest then?
The drugstore, the pharmacy owns the drugs.
Not the 340B. Anybody who does 340B, you know that.
I need to
The
read the
clinic
bill
that
again.
the FQAC who operate those, they bought the drugs, so the pharmacy who operate they only get a dispensing fee of the 340Bs. They don't own the drugs. Somebody can correct me if I'm wrong.
Yeah, you're correct. We operate a 340B program in our pharmacy along with Asian Health Services. They own the drug. We dispensing it through our pharmacy. We don't have a machine, but they pick up at our pharmacy.
I'm
but-
talking about in 2037, allow a pharmacy to provide pharmacy services to outpatient covered under 340B. So allow a pharmacy to provide pharmacy services through the use of an automated drug delivery machine.
Yeah, but I think I would expect that's only for 340B drug only.
I'm okay with that.
Yeah, so in this bill will be a little contradiction to our 1447. When you authorize it's owned by pharmacy, and now in the other way, you said you allow ADDS in the place where the pharmacy doesn't own the drugs. Now, won't there be a little contrast?
You're telling me that in
This-
2037,
Why
the farm...
these provisions wouldn't fit in 1447 is what
Right.
you're saying, because there the pharmacy owns and controls the drugs. Here, the pharmacy owns the device that's going to provide the drugs, but the drugs are owned by
Owned
another
by
entity.
somebody
So the
else.
two bills cannot be completely synced. It is a separate
What
case.
does pharmacy services, provide pharmacy services mean? I mean, you know,
There's no pharmacy service. Actually, you just allow the clinic to buy the drugs and they dispense it to the patient.
But
Well, I think
the pharmacy's controlling the drugs.
Yeah.
Yeah.
Pharmacy
They're
running
filling,
it.
they're filling the ADDS machine.
So let's
Yeah.
get back to the consumer for a second. So aside, well, I'm assuming that if the pharmacy is providing pharmacy services, that the licensing and the oversight of everything remains in place with, let's say, the pharmacy board. The issue is it going to help with the delivery of 340B drugs or drugs to a clinic that services 340B patients. And in my mind, if it's going to do that, then why not? Regardless of who owns the drugs, who owns the machines, if they need a bill to get a machine and a 340B clinic to dispense whatever they're dispensing for the patients, I can't find the flip side of a coin that isn't good here.
Well, I guess I'm kind of opening my eyes because if the pharmacy doesn't own the drugs, then maybe our other bill won't apply. And so we
Exactly, that's
kinda-
the point.
So we kind of almost need to do this to make it complete.
And you've got the added
That's
benefit
accurate.
that in the bills, the drugs removed from the ads for a patient shall be labeled pursuant to our law, which means the pharmacy's going to have to do that, and the pharmacist shall review and approve all orders before they're removed. So there's the patient safeguard with the pharmacist review prior to dispensing.
And how about the patient consultation part on this machine?
They have to
at
have an
the-
audio and visual,
At the clinic?
yeah, they have to have an audio and visual through the machine.
Is there a provision in the bill? Or is that going to be
Ken, did you
regulated by the
have
board?
a motion somewhere in here?
I do
Yeah,
have a
There's a
motion.
motion and a second.
Yeah.
Okay.
Yeah.
And so if there's no more public comment, I would call for the question, Mr. President. Please.
Well done, well done.
That was pretty circular.
Okay,
The board may wish to restate the motion before it votes.
Support.
Stan moved to support the
Alan
bill.
seconded.
And Alan seconded, right?
Yep.
Okay, all right. So I just want to make sure that they, with the machine, they will have, with all the, they will comply with all the Board of Pharmacy regulation, with the consultations and the, all the
The kind of
label
audio and visual.
requirements, right? Okay.
Does.
All right, any further discussions? Public comment? If not, call for the vote. So all those in favor, please raise your hand. Oppose? Abstain? Okay, motion carried.
That was easy enough.
Yeah, that was,
How many more of those can we
that was
do?
slam dunk. Okay.
Actually, Stan, thanks for making us look at that, because I think we didn't realize that our new bill's not going to cover this. I'm not sure if that's what you went into it thinking, but I think
Sure it
we
is,
figured it out.
sure it is, sure it is.
Okay, let's move on. AB 2486. The bill requires manufacturers and wholesalers to report to the board their share of the market of opioid drugs and pay into the Opioid Prevention and Rehabilitation Program Fund. This fund would be used to distribute money to counties for opioid prevention and rehabilitation programs. Staff spoke with the author's office after the agenda for the meeting had been approved and was informed that the author does not wish to move forward, so that's the end of that. Next, SB 212. This bill would establish the pharmaceutical and Sharps Waste Stewardship Program in California. The statewide program will be established by the manufacturers of covered drugs as defined and will provide convenient receptacles for the return of pharmaceuticals and Sharps. Staff has worked with the authors and CalRecycle and continues to provide technical assistance. Board staff will be prepared to discuss the measure in more detail should the committee board so choose. As written, staff believe compliance with the board's drug take-back regulations would still apply, and the board would remain responsible for enforcement of those provisions. Now, CPHA has an oppose unless amended, asking for flexibility for pharmacies, and they're working towards getting that done. That's just a little additional information. Now, I have to look one other place to see if anything else happened. Okay. During public comment, individuals sought clarification regarding preemption of county ordinances. Subsequent to the meeting, staff confirmed that preemption language is included in the measure. Do I hear a motion for anything on this bill?
The subcommittee didn't make a recommendation.
Subcommittee did not make a recommendation. Yes, no?
Let it ride, I mean, it doesn't
Okay.
seem like it's gonna have much of an effect on us.
Okay, any comments? Okay, We'll move along. SB 1021. This bill would eliminate the sunset date on provisions of AB 339, capping monthly copays at $250 total per patient, preventing discrimination against patients with specific conditions by ensuring that all the drugs for a given disease could not be placed in the most expensive tier, and extending all protections to plans in the large employer market, as well as the individual and small employer coverage markets on January 1, 2020. Amendments made in Senate Health Committee added language similar to AB 2863, capping the copay amount at the retail price if it is lower than the copay. The committee yesterday recommended support of the bill. Do you have any comments, Public?
All right, we need a motion to support.
I will make a motion to
Yes,
support.
we need a motion to support.
And we have a motion and a second. I'm the motion.
Moved by Greg and second by Cheryl. Any further discussions?
I just, are we getting into an area that's not really part of our purview?
Yeah.
I mean, I just don't think we should be talking about copays. This is not the business of the Board of Pharmacy. I think that we should remain silent.
Well, I think that for purpose of the consumer, this is pretty important.
I mean, consumer protection, I mean, are we supposed to now
Yeah.
protect them against copays?
Well, we're
But what about
protecting them
pharmacy?
we're protecting them in the way that they can't, you go into the pharmacy and the pharmacy knows that the actual price of the prescription is less than your copay, but they don't tell you, and you wind up paying more than you should. I think that's a consumer protection issue.
But I don't think that's a consumer protection issue for the Board of Pharmacy.
Well,
That's your opinion. Have mine.
you know,
We
but
each have our opinion.
essentially, what this is doing is it's eliminating the sunset date on a provision that's in effect now.
Already exists, right.
So there's, essentially, it continues as it is.
Correct.
Right, I mean, I'm not debating the bill.
Yes, you are.
I'm debating whether the Board of Pharmacy should take a position on this bill.
All this is doing is, like Alan says, it's extending the sunset.
I think this is the business, and we're not we don't regulate this.
I know what you think. Stated it.
All right, any
I
other,
know what I think.
any public comment? Any further discussion? If not, let's call for the vote. Okay, all those in favor, please raise your hand. Oppose? Abstain?
You didn't oppose?
I'm abstaining, because I don't think we
Abstain.
should be even, this shouldn't have.
Okay.
2 abstain? Okay, motion carry.
Okay. Moving along. SB 1254. This bill would require a pharmacist at a hospital pharmacy to obtain an accurate medication profile or list for each high-risk patient upon admission and discharge of the patient. The criteria for determining whether a patient is high risk will be established by each hospital. Additionally, the measure would allow for this duty to be performed by a pharmacy technician or a pharmacy intern if they have successfully completed training and proctoring by a pharmacist and where a quality assurance program is used to monitor competency. The measure is being brought to the committee to seek input on the policy of the measure. The board previously heard a presentation on a study underway at Cedars-Sinai regarding high-risk patients. The measure was brought to the board in May. No position was established at that time. And let's see. The committee is recommending support. I want to see if
Subcommittee.
the subcommittee recommended support.
I think it's a noble idea. And Jeff Stone is a pharmacist, and Rita Shane is a leader in the hospital pharmacy industry. So both very credible people.
Do you want to make a motion?
No. But thank you for the opportunity.
I'll make the motion.
No, I have a question.
Yeah.
So, a patient is brought in by an ambulance to an emergency room. How does this, I understand high-risk patients, and I understand the critical need to get the information. But sometimes it's just not available. Or sometimes a patient is dropped off, a dementia patient's dropped off at a hospital, or you have patients comatose, semi-comatose, patients who can't, how do you get the, again, it's a noble idea, but practically, how do you do it? I don't know.
I think I'm with you, the require the hospital pharmacist has to do this, that makes me a little nervous. I would think.
That's what I'm.
This is a best practice that I would think every hospital out there would do. Do we have to regulate it, though?
Well, I think every hospital should try to do this, and maybe they all
Why
do.
would- Yeah.
But I don't know how you can
Require
demand
it.
it. I mean, you're in a hospital, how do you do that, Marie?
I think it's a complicated issue because there's the belief of what is the right thing to do, and those things do happen. But oftentimes, it's the regulation or the legislation that gets you the resources to be able to do the right thing.
But what about requiring you? So what if, like,
Not required, I don't get resources.
Fired what?
I may
Doesn't
not
get
get resources.
they don't get resources?
Well,
They support the
Yeah,
bill.
and right now, I guess the issue is there's a lot of errors that are occurring, and what's happening is the people that are currently taking the med list.
I don't think we're opposed to the purpose. I think it's just, do we
The practicality of it,
Yeah.
I can't get.
now,
it's common sense that this should happen.
What?
And I guess if it's not happening, and the only way we can make it happen is to support legislation, then, I mean, if the hospitals won't do it on their own and we have to have a regulation.
A
Crazy.
hospital's so at risk these days.
I think the only thing you can make it similar to or equate it to is the years of ongoing work on the board to enforce consultation. If there was not a consultation regulation, would it be happening?
That's been successful.
I was gonna say, I'm not sure that's the
We
strongest
have-
argument we've got
We
here.
have public comments.
Okay.
Steve?
Steve?
Steve Gray, pharmacist, and I've been very much involved with Senator Stone's group and where this was brought forward from Cedars-Sinai, where they've studied this extensively. First of all, Stan, the law cannot require you to do anything that is impossible to do. That's just a flat statement. This bill does not require you to do it before the patient is admitted. It's just required to be done. What happens in emergency situations, and there are now hospitals that have pharmacists full-time in emergency rooms. And so some places are already doing it. Hospitals that are concerned about 30-day readmissions for cardiac patients and so forth are already doing this for those types of serious patients because they've learned they're going to get dinged financially if that patient is readmitted. So it is happening. The issue is exactly what Board Member Serpa said. Hospitals are not going to use pharmacists to do this, even though they're the best trained and the best trained to train people like technicians and others to do this, because pharmacists are expensive. So this is an attempt to start in the process for the most serious patients, as defined by the hospital and the medical staff and so forth, where they want a really good, high-quality, current medication profile before they start, if possible, but before they finish treating that patient in the hospital. And it does take time, and it often takes time when you're during business hours. The problem is that some hospitals make minimal efforts on this because that's been the tradition or
Right.
the usual
And
practice.
they use
There are
clerks to
hospitals
take
that use
information.
clerks, admitting clerks. Some use volunteers, if you can believe it, and others try to use RNs and so forth. But hospital RNs, as good as they are, and they're highly professional and caring, but they don't know the outpatient world. They don't know how to get this information. I've heard it said, it's just a summation. It's not a derogatory remark, but the people that are doing this now need to know how to contact a PBM, and these are people that don't even know how to spell PBM. You know, and I mean that because it's complicated to get this information. And yet, ironically, some of your most serious patients, think of patients on multiple drugs with multiple diseases who are going through changes in their health status, their drug therapy outside the hospital may have been the exact reason why they were admitted to the emergency room or the hospital. And if you don't have an accurate picture of that, you don't know really how to diagnose and correct what's going on, or worse yet, on discharge, you send them back to the same environment that got them there in the first place.
Yeah, but let's.
So all this bill does is shift the requirement for the hospital on who is doing this.
I'm just talking about practical here, and let's get practical for a second. Flowing words are great. However, this bill would require, the bill would require upon admission. And so you get somebody in your emergency room, admission could be an hour later, it could be 3 hours later, it could be the next day.
Right.
But you get somebody who's compromised in the emergency room, and you're going to tell me that the RN should call the PBM. Now, that's a great idea because nobody can get a hold of anybody at a PBM. We just had a discussion. You have a dying patient can't get their PBM and get their medication. So the idea of believing that a PBM is going to respond to anybody, I find to be extraordinary unless you've got a phone number or access to numbers that the PBM's patients don't have.
I think you're overreading the words upon admission. Upon admission.
Overreading. I'm reading.
Upon admission means what triggers the requirement for the hospital to start the process. It actually, as anybody who's worked in those situations lately, it takes sometimes days to get all of the information. And you got to contact the patient. If the patient isn't available, you got to contact the family or the caregivers. You contact the pharmacies they're using, and in some cases, because the patient used multiple pharmacies, you find out what their insurance is, and you contact the PBM. The on admission just triggers the start of the process.
That isn't what it says.
But that's what the study showed, and that's what the process described to Senator Stone on the bill and everything. It's what's understood. Now, if you want to go back and change it, starting upon admission, and there are differences because there are, as you well know, there are observation areas in hospitals where they're not admitted to the patient sometimes for days. But this says if you're going to admit this patient to the hospital, diagnose them, treat them, test them, and then eventually discharge them, you need to have a program run by pharmacists that tries to get an accurate list of their current medication therapy. That's all they're trying to do.
I think it's critical to have that list to treat a patient. I'm saying that sometimes it's impossible. And I'm saying upon admission, as far as I can tell, means upon admission, and it doesn't mean 3 days later, because often the patient is discharged by 3 days.
If you look at the bill
Yes,
language,
Maria?
the actual language does say that the criteria will be established to define high risk and to determine the time frame of completion. So admission is not hours or minutes or maybe even a day. It's to be established by the organization.
Thank you.
And we have to, we may have the opportunity, it's a may and not a shall, do regs in this area.
Right, any other comment?
Robert Stein, KGI School of Pharmacy. Yeah, it's important to recognize that the bill, as currently written, does permit the hospital to determine what that time frame is after admission, as well as the definition of what a high-risk patient is based on that hospital's patient population. I do want to also mention, because you were talking about the PBM and getting a hold of that. Again, I implore the board to start thinking about the possibility of adding all dangerous drugs to the cures database. I know it's going to be a huge political fight to get DOJ to do that, but that would obviate the issue of having to call a PBM to get the information, because it would be available to all healthcare providers taking care of patients.
Any other comments from board members?
Well, here, another addendum here in the bill is that it can allow for this duty to be performed by a tech or a pharmacy intern, which broadens the scope of the program. But, one of the things that I don't like about, a bill to require a hospital to obtain this, and here we're making sure that it's going to be done by a pharmacist through the hospital pharmacy. But, gotcha on accurate medication profile list. I think just plain medication profile list, because, there's no sense in getting a medication list if it's not accurate. I think that goes, I don't think that has to be specified there. And I look on that as a regulatory gotcha that might be used sometime that would be unnecessary.
Does CHA have a position on this?
They support it. They've actually kind of worked as a co-sponsor.
Well, actually, there are many ways to do
Okay.
that. The technicians or the interns could even send a request to the retail pharmacy that the patient was using and get a medication list so they could do the reconciliation with the patient. I mean, this is a good public, I would think it's a good public protection for the patients to reduce readmission, especially for the high-risk patient. It will be a good tool both for the profession and the consumers. Okay, so I need a motion from the board, if you want to.
I did the motion.
Okay.
I think Cheryl seconded
Motion
it.
by Greg and second by Cheryl, so let's call for the vote without further discussion then. For all those in favor, please raise your hand. The motion is to support.
Support.
All those in favor, please raise your hand. Okay, oppose? Abstain? Okay, motion carry, great.
It's not voting, but whatever.
Okay, thanks.
Oh, you did, oh, okay, I just can't count.
Okay, that concludes the legislation portion, and now we're moving on to the regs.
FYI.
But this is going to take a half hour this morning.
You mean that last bill?
It could have. It could have. Okay, so, did you want to take a break in the middle, or do you want?
I mean, do you,
Oh.
yeah, I think we,
Is this gonna go quick?
going to go quick, I mean, it's all
It
FYIs.
will, as long as nobody extends it.
But it's all FYIs only, or we're going to take a break. I think we,
It's gonna go.
we'll, let's finish it.
Let me start it.
Thank
yeah.
you.
Okay. All right. I
have no other
This
remarks.
is regulations.
Greg, we do need one, there is one vote.
Which
It'll be
is-
on your
oh,
updated sheet, it'll be on your updated sheet regarding the emergency reg.
Oh, okay, right. So, Debbie, don't go yet. It's the first one. Okay? This is for readoption of emergency reg. This is, the readoption amends the board's regulations regarding the establishment of compounding beyond use dates on an emergency basis. Emergency readoption was approved by the board in May, will expire September 18th. Non-emergency regulations will be filed with the OAL on August 3rd, 2018. 45-day public comment period will end September 17th. After the 45-day comment period, DCA must perform their post-notice review. It is necessary to adopt the emergency regulations once more so that they will stay in effect until the non-emergency regulation can be promulgated by OAL. So, yes.
All right, move
I'd like
moved
to
by Debbie.
move that we adopt the emergency regulation, or we continue the emergency regulation, whichever is the better way.
You're readopting the
That we
emergency.
re-adopt was like the
Readopt,
next
yeah.
thing I was gonna say.
Okay,
All
I'll
right,
second it.
Moved by Debbie, second by Greg. Any further discussion? Public comment? If not, all those in favor, please raise your hand. Oppose? Abstain? Okay, motion carry.
Okay, great. Okay, Debbie, you can go.
Thank you.
Okay, next. These are regulations, board approved to initiate rulemaking, undergoing pre-notice review by the Department of Consumer Affairs or the Business Consumer Services and Housing Agency. Okay, all of the following proposed regs amend or add to sections of Title 16 of the California Code of Regulations. The first one is to amend sections 1735.1, .2, and .6, and 1751.1 and .4. The regulation formally amends the board's regulations regarding the establishment of compounding beyond use dates as it relates to sterile and non-sterile compounded drug preparations. Additionally, this regulation allows for the use of a double filtration system. Okay. It was approved by the board July 25th, 2017, and submitted to DCA for pre-notice review November 20th, 2017. And didn't we have some activity on that recently?
The pre-notice review was completed. It's currently with the Office of Administrative Law awaiting publication.
Okay, great. Next is to amend sections 1780 to 1783 et sequel related to third-party logistics providers and dangerous drug distributors. The regulation establishes the regulatory framework for third-party logistics providers. The proposed regulations, sorry, I'm just dealing with several different updates here. Okay. This was approved by the board October 26, 2016, originally submitted for pre-notice review February 9th, 2017, has gone back and forth a few times, was resubmitted to DCA for pre-notice review again on June 28th, 2018. Next is to amend section 1707 related to offsite storage. Regulation amends the board's regulations regarding the waiver requirements for offsite storage of records to allow those cited for a records violation to receive a waiver to store records off-site. This was approved by the board January 24, 2017, originally submitted to DCA on April 27, 2017. Back and forth, resubmitted to DCA for pre-notice review July 13, 2018. Next, to amend section 1746.3 related to the naloxone fact sheet. Regulation amends the board's regulations regarding the naloxone fact sheet that must be provided to consumers upon furnishing naloxone hydrochloride. It was approved by the board May 4th, 2017, originally submitted to DCA on May 31st, 2017, but went back and forth, was resubmitted on June 13th, 2018. Next, to amend section 1709 related to pharmacy ownership, management, and control, including through trusts. The proposal amends the board's regulations regarding ownership to include provisions relating to trust ownership of pharmacies. This proposal amends the board's regulations regarding ownership to include provisions relating to trust ownership of pharmacies, and it was approved by the board on October 27, 2016. It was originally submitted for pre-notice review January 26, 2017, resubmitted to, came back, resubmitted to DCA for pre-notice review May 24, 2018. And this one has had no activity for more than 30 days. Next, to add section 1717.5, 1717.5 related to automatic refill programs. The regulation establishes regulatory requirements for automated refill programs. It was approved by the board on May 3rd, 2017, originally submitted to DCA for pre-notice review November 7th, 2017. It was resubmitted to DCA for pre-notice review on June 29th, 2018. Next, to add section 1793.9 related to remote dispensing technicians. The proposal establishes regulatory requirements for pharmacy technicians working in a remote dispensing site pharmacy. It was approved by the board February 6, 2018. It was submitted to DCA for pre-notice review on June 11th, 2018, and no action since then. Next, to amend section 1706.2 related to abandonment of applications. The regulation updates the application's abandonment language to include all licensing programs to ensure that all applicants have appropriate notice about the requirements for abandoning an application and reduce the administrative workload associated with the need for frequent amendments when new licensing programs are established. This was approved by the board on February 6, 2018. It was submitted to DCA for pre-notice review on July 2nd, 2018. Next is to amend 1793.5, .6, and .65 related to the pharmacy technician application, the pharmacy technician training requirements, and the pharmacy technician certification programs. The regulation establishes the training requirements and certification programs and updates the application for licensure for pharmacy technicians. This was approved by the board October 26, 2016. It was submitted originally to DCA on January 23, 2017. It's gone back and forth. Finally resubmitted to DCA for pre-notice review on July 11, 2018. And next is to amend sections 1707 and 1702.1.2 and .5. Regulation updates the renewal requirement language to include all licensing programs and reduce the administrative workload associated with the need for frequent amendments when new licensing programs are established. This was approved by the board on May 2nd, 2018, and submitted to DCA for pre-notice review on July 12th, 2018.
While I appreciate your inspired reading of this, what order are these 10 items in?
What order are they in?
Yeah, how did we list them on here? Is this the amount of time it took, or when it was, it's not when it was approved?
Ann's going to have to answer that one. I don't know.
I don't think that there's any specific order. It's broken down into categories, but we don't like do it by section or anything else. I think
Okay,
it's
it's
just
just
as
as is.
things have
Oh,
been moving.
okay.
However, having said that, if there's a desire to put them in date order based on when the board approved the language, we're happy to do that. There's just currently no rhyme or reason.
Okay, I'll think about that.
Thank you. Next, board approved to initiate rulemaking. Documents returned to the board for corrections to be made by staff. The first one is proposed regulations to amend section 1715 to update self-assessment forms 17M13 and 17M14. The regulation updates these self-assessment forms. Additionally, the regulation updates section 1715 with clarifying language as to the completion and certification requirements of the self-assessment forms. This was approved by the board November 8th, 2017, returned to the board on April 17th, 2018, after having been submitted for pre-notice review on February 2nd, 2018. Next, board approved to initiate rulemaking. Documents being prepared by board staff for pre-notice review. First one is regulation to amend section 1735.2 to update the compounding self-assessment form 17M39. Regulation updates that self-assessment form and additionally updates section 1735.2 with clarifying language as to the completion and certification requirements of the self-assessment form. It was approved by the board on November 8th, 2017, and the board staff recommends that the regulation be on hold pending action by the USP and the board's statutory proposal that would incorporate relevant chapters of USP into board regulation. Next, would amend Section 1784 to update self-assessment form 17M26. Regulation updates that form. Additionally, it updates Section 1784 with clarifying language as to the completion and certification requirements of the self-assessment form. It was approved by the board on November 8th, 2017, and board staff anticipates the regulation will be submitted to the department in mid-August of 2018. Next is to amend Section 1707.2 related to mail order pharmacy consultation. The proposal amends the board's regulations regarding the duty to provide consultation for mail order pharmacies. It was approved by the board May 2nd, 2018. It was submitted for DCA pre-review on July 23rd, 2018. That's the end of the regulations, and that's the end of my report.
Thank you very much, Greg. Okay, so now the board's going to go into closed session, and we might reconvene after the closed session.
Oh, when it gets here.
Board business.
Yeah, we'll go back.
You'll go back into open session for the purpose of recessing. And I would just clarify, Mr. President, if I may,
Yes.
that the litigation item, there's no case numbers to announce because we don't have any litigation items.
Okay, all right. So, so we'll go into closed session now? All right, thank you.